everybody. This is Preeya Gupta with Interventional Mindset. And today we're going to be talking about collaborative care models for glaucoma management. And I have two amazing doctors with me today, Dr. Deborah Ristvedt and Dr. Matt Walker from Vance Thompson Vision in Alexandria, Minnesota. Thank you guys so much for being here. I am just particularly excited because I feel like I'm going to learn so much by talking to you two who have really, to set the stage for our audience. Deb and Matt have really developed this collaborative care team to really change their practice from kind of a comprehensive ophthalmology practice to really an interventional glaucoma focused practice. Matt, you're an optometrist. Deb, you're a cataract and anterior segment surgeon, and you guys work together day in and day out to really focus your practice on this really big unmet need. So walk us through just a little bit about, how you guys, came up with this idea and kind of what are some of the ways in which you've optimized focusing on interventional glaucoma.
Well, thank you, Preeya, so much for having us. We're just so excited to share our story because it has made the joy just that much more when you talk about, how we're practicing on a day-to-day basis by working together and collaborating together. In 2011, I joined my dad in practice as a third-generation ophthalmologist. And as he retired, I was rethinking how I could do things better in our community. And that's where we decided to build a surgery center as I was operating at the hospital. And I wanted to take care of our patients in more of an efficient manner, as well as grow, as I was limited to block time. And so along the way, I met my good friend John Berdahl at Vance Thompson Vision. And just walking into their building, it was all about servant leadership and the best technology and making sure that their patients and team are really taken care of. And so at that point, we were talking to this brilliant doctor, Dr. Walker, down in Florida, who's actually my husband's cousin. And he had been in practice for 10 years. And we said, hey, Matt, we're looking to grow and to build a new clinic and surgery center. Would you be interested? And so at the same time we joined Vance Thompson Vision, Matt moved from Florida back to near his hometown in Minnesota to be closer to family.
Amazing.
Yeah, definitely been a journey from when I was in Florida working for a surgeon. We had two kind of separate practices within a practice. He does his thing, I did my thing, and it went really well. We saw some cataracts and we thought we were pretty busy. But then the model of Vance Thompson Vision is totally different, where not only am I seeing patients, but I'm seeing surgical evaluations, consultations, which, takes a lot of trust from Deb. I was doing it for a decade and I thought I knew, my way around a clinic. And it was almost like a residency my first year again, because I had to not just know about the surgery, but it inside and out enough where I could talk to any patient about any surgery that Deb does. So then they have the same confidence that Deb would if she was speaking to them.
And Priya, not only that, but he's not, he's too humble to say he had to like literally gain the OD referral trust when it came to sending patients to him first, right? And so that was huge to be able to go out and build relationships and educate his peers so that not only are they better, but we're better as well, that we're collaborating within the practice. So it's kind of twofold that happened over the last course of 7 years, where we built this beautiful model so that we can really practice at the top of our game.
So in your model, for the audience, the reason to do something like this is because, as many ophthalmologists as there's way more patients than ophthalmologists, right? And if ophthalmologists are seeing a lot of comprehensive care, or, if they're subspecialty ophthalmologists and they're not really only focusing on their subspecialty, we're not going to have enough ophthalmologists to take care of all of these patients surgically. So, kudos to you guys for being a referral center and growing that trust. When Matt, when you first started, what are some of the things that you kind of did in terms of outreach and education to really establish, that not just that trust, but also yourself as an expert within interventional glaucoma?
I think we have a unique situation in rural Minnesota where we have a substantial amount of glaucoma and not just primary open angle, but pseudo exfoliation, where these doctors kind of had already the burden of, oh my gosh, we have so much. What do we do? We need help. And Deb has, even before I joined, had meetings at our local restaurant to educate on the iStent or Omni or all of our MIGS devices. So she kind of already started that pathway. And before I got there, and then we joined Vance Thompson Vision, all of the ODs in our network already knew about John and Vance and how things were going there, where we don't see routine care. You get your patient back once we, take care of them, get them to a stable place. It's back to the OD. And then from my end, I just see him at all the local meetings. How's it going? Or I'm presenting on MIGS one day, and then we get info. So it's definitely building that trust, from ODs, and it's, helping them with other things along the way. And even though like Deb is the nicest person on the planet, sometimes she, to have a surgeon is intimidating because you're going to put yourself out there if you send a communication that like, oh man, I don't want to look dumb. Well, I've been in primary care where I used to not know what I knew now. And now that I do, I'm able to kind of translate, oh, I've been there. This is why we went this way.
Makes sense. You're almost like an approachable, a liaison that's approachable, because Deb's so scary, obviously.
Terrifying.
I am. I'm really scary.
You're so scary. I'm often scared by you. It's true.
Thanks.
So, in terms of like, how do you guys, like, I'm just thinking, like, let's say I was a patient and Matt, I had only met you, and like, I've never met the person that's going to like actually do surgery on me, right? I mean, you're wonderful, you're nice, you've recommended a surgery, I'm probably freaking out inside that I need surgery, and now I'm rolling up and I'm going to see Deb. What does that look like in terms of, kind of behind the scenes? How do you guys have that seamless transition to take, because obviously you care the most about the patient, you care the most about, providing them that essential surgery that they need, but how do you guys stay on the same page and communicate, etc.?
Preeya, number one, I feel like having this model where Matt and I are collaborating together and we're almost like one unit, but he's keeping me in the OR most of the week. I feel like I have more time to get to know that patient before surgery. It's so interesting that way. And with our model, we have something called FORD. It stands for Family, Occupation, Recreation, Dream. And the text will fill out little nuances about that patient so that I understand who they are. So whether they're coming in for a premium IOL or whether they have glaucoma, I know what they like to do, their activities of daily living, their grandkids, and what they do. I mean, it's just so nice to be able to have that relatability with your patients, so that you can build trust. And I love how John Burdall always says, trust is built on small encounters. And so when I was a comprehensive ophthalmologist doing everything on my own, seeing 60 patients a day, trying to keep up, I just never felt like I was truly engaged. Where now I feel like Matt and I have gotten into a rhythm where we know our algorithm. If he's questioning something, we have this little Google chat box that goes on throughout the whole day. So I may be operating and there's a little chat saying, hey, Deb, I need you for this. Or, hey, what would you do for this situation? And so I always feel like we're really openly communicating so that we're on the same page. But it's so interesting, Preeya, how with interventional glaucoma, we've gotten down to the rhythm of this new algorithm where a lot of times I'm not changing plans. I mean, it's maybe less than 1% of the time now that I'm changing because we know that algorithm and we know what works and what responds. And so it's just so cool when you can see yourself and your partner grow together. And that's what's happened.
Love
I
that.
love using the bat phone. I feel like in my old gig, I that's what we call it. And she can pull up the whole patient chart, the visual fields, like all the OCTs right there as she's operating, and I can say, I'm in between these two. I think it's this one. What do you think? And it's a totally different way than my first 10 years where I needed to make the decision. I'm the doctor, and if I leave it to somebody else, then I fail. No, like the so it took me some time, right, Deb, to figure this out. Where if I'm not 10,000% confident, like go to Deb to confirm. And since we've done that together for 7 years, that's why we're 99.2%
Yeah,
on the same page.
Yeah.
right. Like it would be weird if you disagreed at this point.
We have good conversations for sure. I
Yeah.
try to win, usually I don't.
And
Um,
also, Priya, like I thought patients were going to have a really difficult time
yeah.
because they don't meet me until the day of surgery. But again, it's that trust is built on small encounters. We send a video before they come to our office. So it has me explaining who they're going to meet, what we're going to be doing at the time of exam, and that I can't wait to meet them. And so it really shows that we're egalitarian. We work as one. No one's higher than the other. Same with our techs or front office people. Like we're all united and we want to give them the best experience possible. And this is a way we can do it.
I love that. I mean, I think it's so critical. And are there other people besides the two of you that make this possible? Yeah, is there anyone else in your care team that's kind of like, just looking to the audience, and I'm sure there are lots of busy people that would love to, take the step forward, like the leap of faith that you guys took, and to start something amazing. But what are like the practical items that could help, a surgeon kind of looking to do this?
I think developing trust is number one. Finding someone that really wants to be alongside you. And, that's what I found in Matt, where not only is he fun and funny, he's enjoyable to be around, but also he has that drive to learn and he's hungry to be excellent. And so there's so many practices out there now that are using this model because it just is so efficient. It's fun and it really provides the best opportunity to get the surgeon back into the operating room where we need to be a lot of times. And so I think number one, it's finding someone that you could see along your side and really developing that relationship. Be looking, at different meetings, ask your colleagues, ask your friends if you have any connection to optometry schools or residencies. That's huge because there's a lot of these OD residencies that really teach anterior segment or they go beyond, their 4 years. And so there's so many opportunities like that to kind of reach into to say, hey, is anyone looking for a position? And then it's truly, having your staff come around you and say, okay, like we're going to help you develop this new model. And so at first, it's a little wonky because, they're used to you being in the clinic all the time, right? And so it was really Matt coming in and establishing that trust with our team as well that really created this beautiful environment where they felt actually that they got responses faster because they had that one-on-one attention. And so, have your team kind of get behind you when it comes to bringing someone else on board. And then number three is your OD referral network. That's crucial to developing trust to say, hey, we're hiring Dr. Walker. He is awesome. We trust him so much, and he's going to be helping us to create the best experience for your patients so that, we can, again, take care of them as soon as we can or as soon as possible. And so those would be the three key things for me. How about you, Matt?
I would say that if you have the goal to BIG, you need to BIG and get rid of comprehensive care. Not get rid of, but find a home for it, whether you're an optometrist, ophthalmologist, like if that's your dream. Um, but then I'll bet if we left it on Deb to make that happen on her own and she was in the clinic, there's no way she's such a pushover that it would still be full of routine care. And everybody, I mean, Deb was doing retina injections and all the above. So because I was new, I didn't have the personal I cared for him and still do, but I was like, we're moving. And John Berdahl, when I first joined, said, this is your task, is to transition us from a comprehensive to IG. And so all of the routine diabetics, macular degeneration, dry eye, like that's not us anymore. And it was a tough thing because in a small town, everybody knew Deb and her dad and her grandpa. And I was probably not a very liked guy for the first few years. But then think of the OD trust. Since I got to know them and have for 7 years, I'm able to say, well, these group of doctors, or here's your list that would be able to manage and have the OCT visual fields to do this. For routine care, you go here, and they're full schedule now because we released those routine care patients back to the community. So instead of us trying to prove our trust to them and tell us, hey, we're not going to do routine care, we literally showed it to them. And I think that's why it was so effective. And then from Deb's end, like, she has the time to talk to the patients. I do too, because I don't have 30 VSP exams that I have to refract through and all these dry eye and plugs. I mean, we do some, but I have a scheduled time to review options with patients, and then they and I decide together, this is why this will probably be the risk balance reward and why this is the right way to go. Here's why, Deb does what she does and why she's awesome. And here's a video to back it up. And so questions are answered comprehensively before they go. So when they see Deb, then they get to work.
I love it. That makes so much sense. And it's you're right. It is having those multiple touch points. I think that's also, really critical on a, just a total buy-in level. So I think that's amazing. I mean, I feel like you're challenging my thinking. And, as we're chatting, I'm like, oh my gosh, there's so many ideas that so many doctors out there, that are already maybe in collaborative practices, can take from you guys. So thank you for sharing those tonight. I think that we're going to run out of ophthalmologists at some point, right? And so, we have to be a little bit more creative in these collaborative models. And, I'm a little jealous that Matt's in Alexandria, Minnesota.
I know, don't steal them, Preeya.
I'm just saying it's a little bit warmer in North Carolina.
Mountains.
And
Right.
Matt, Preeya's awesome. So I'd be okay, but I would miss you dearly.
I would never do that. I'm from Minnesota, so I can't
I know.
Oh, for sure. Oh, yeah. But seriously, thank you guys so much for sharing, the ins and outs of your model. And really, I think interventional glaucoma as a collaborative model is so much more successful and efficient, as you mentioned it, but really, is a good experience for the patient. And so if that means that we can see more people, help more people not go blind from glaucoma, and do it with, kind of the patient at the center of it all, I think that's an amazing approach. And so I thank you guys for sharing.
Thanks for having us.
Of course. Bye.